Dr. Ed Loftus from Mayo Clinic Rochester, and I'm with Dr. Corey Siegel from Dartmouth-Hitchcock Medical Center.
At this year's DDW, our group covered safety in IBD therapy. The topic that I found most interesting to bring from the podium to your practice was around drug safety around time of surgery. The controversy that we've been thinking about over the past couple years, and we always work with our surgeon on, are do we have to stop drugs before, and how do we have to wait until after surgery when it's safe to restart them, because we're worried typically around post-operative complications and infections. The reassuring signals that we saw at this meeting were whether it was non-intestinal surgery or intestinal surgery, that patients on vedolizumab don't seem to have an increased risk, and there had been particular concern around vedolizumab over the past few years. One abstract looked at comparing vedolizumab to anti-TNF drugs, and there was really no difference between the two. So again, some reassurance that one of the newer drugs we have in our armamentarium, which is vedolizumab, does not lead to increased risks. The other topic I found really interesting was around joint replacement surgery. And this comes up with our orthopedic surgery colleagues all of the time, where they ask us if we have to stop the drugs and how long do we have to wait to restart them. But again, a reassuring signal here that whether they were on immunomodulators or anti-TNF therapy, there was no increased risk. But we saw that we've seen in many cases in IBD treatment and adverse events is that it's the corticosteroids and narcotics that increases the risk. So how's this going to affect your practice?
Well, I think that last one is a really clinically relevant scenario. It happens all the time, and so maybe we can be more confident in saying, no, we really don't want to stop our effective therapies for IBD for non-intestinal surgeries, and in particular joint replacement surgeries. It also raises the issue, maybe that original study which came from our center was confounded by disease severity or concomitant medications.
Talk with our surgeons, right? Work with them as a team and make sure they understand the data that we have in our setting. What were you most interested in?
I was interested in tofacitinib's safety because that's a new drug. It just got approved for moderate to severe ulcerative colitis. This is a drug that has a black box warning for infections and malignancy in the RA experience, and we wanted to see what the experience was in the ulcerative colitis population. And in particular, the zoster risk is what stood out the most. At the 10 milligram twice daily dose in the maintenance cohort, there was an increased risk of zoster. It was about an annualized risk of about 5 or 6%. It did not go up with time. Most of those were not serious or opportunistic, but it is a real issue, and we have to monitor our patients for one, and preferably vaccinate them before starting tofacitinib, preferably with the recombinant vaccine, the newly available one. And I think it's a manageable risk.
I think so too. I think that this new drug, tofacitinib, that we have some flexibility in dosing, which is new for us in our drugs. And the fact that there's a 10 milligram dose and a 5 milligram dose, and we could get patients into remission on the 10 milligram dose and then dose reduce, keep them in remission while avoiding this increased risk, to me is a nice new way that we can use our drugs.
Right. Yeah, and any time we get a new mechanism of action in our armamentarium, it's fundamentally a good thing.
Great. These were the topics that we felt most important at DDW to bring from the podium to your practice.